Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
My guest today is Dr. James Anderson. I had Dr. Anderson on the show just about a month ago, Season 4, Episode 21, where we talked about restless leg syndrome. And at that time, I learned about another recent publication that Dr. Anderson published in conjunction with Dr. Forrest Tennant in the International Journal of Pain Management, dealing with how vagal nerve stimulation could actually be a game changer in chronic pain, as they were able to monitor blood biomarkers, specifically cytokines, and show that the vagal nerve stimulation actually changed these blood biomarkers, in addition to making people feel less depressed, less anxious, and much less pain. So I had to get him back on the show, and that time is now. Jim's been a personal friend of mine and colleague for more than 2 decades. He has developed a very prominent and excellent clinic in Fort Collins, Colorado, and in a suburb just north of Denver, specializing in lower extremity peripheral nerve and chronic pain. He has completed some of the best clinical research in lower extremity peripheral nerve that I know of, and his work has been published in some very prestigious journals. Please enjoy my conversation with Dr. James Anderson. All right, welcome everybody to the Pod of Inquiry. I've got Dr. Jim Anderson back. I had him about 4 weeks ago, and I was coming across some of his stuff that he's written, and I just had to get him back here to talk about vagal nerve stimulation. So Jim, thanks for coming back. I appreciate you taking the time.
Thank you. It's great to be back.
So tell me about this paper that you published in the International Journal of Pain Management with our esteemed and loved colleague, Dr. Forrest Tennant.
Yeah, this paper, we gathered data on it, I think it was back in 2019. It's a small study of subjects, of only 33 subjects, and really saw a big change in subjective numbers and also objective numbers using a vagal nerve stimulator. And for those that aren't aware, vagal nerve stimulator, vagus nerve stimulates the parasympathetic nervous system and can be implicated in people with chronic pain. It has a very positive effect from our study of various types of chronic pain that people are suffering from. So, that's the basis of it. And I can get into how exactly it was done.
Yeah, before we get into that, let's talk about the vagus nerve a little bit so that the audience gets a little bit of understanding. I think it's very well established that stimulation of the cranial nerve 10, which is the vagal nerve. I always call it the vagus nerve because when I go to Vegas, I always feel good. It causes me to release dopamine and whatnot. But so the vagal nerve, vagal nerve stimulation has been around in psychiatry for quite a while. It's had a pretty extensive amount of literature published on the benefits from an anxiety standpoint and a depression standpoint. But what impressed me about this paper is that you're talking about centralized sensitization of pain. And then the other really cool thing is that you looked at blood biomarkers.
Exactly.
And that's what's really cool. So let's talk a little bit about centralized pain. And go ahead. Yeah,
I was going to say it might be. I had to do a quick search before we did this, and I think but this might be the only one. I might be wrong, but I think that a study as of yet to really do cytokine measurements. I think they've been done on. I think it was somebody with on a study on Parkinson's maybe, and using a vagal nerve stimulator.
Okay.
And one of the paper, but not specifically for kind of a broad category of patients that we had in this study. And that's what was exciting about it. Just like you said, for me, was the change in cytokine levels.
Yeah, no, in fact, when I came across this paper, I did a literature search as well because I hadn't seen anything in the literature that talked about the change in actual blood biomarkers, i.e. the cytokines. And,
exactly.
I thought that was really pretty cool because it's one thing in the depression papers when you look at vagal nerve stimulation, people will say, well, I feel much less anxious, I'm calmer, but these are all subjective things.
Exactly.
My pain is better or my activity levels increase. But this paper actually shows the change in the cytokines in the blood itself. Again, like we talked about in the previous episode about 4 weeks ago with intraoperative nerve monitoring, it's as objective as you can get.
Exactly. Yes.
So very good job on this. What made you think about this? And then was it just something that how did you even get into the vagal nerve stimulation world?
Years ago, I toyed with it, done just a few patients for pain after surgery. And it was a device that just adhered to the ear. And then another device came out that actually had little needle electrodes that go into the peripheral nerves in the ear that then go to the vagus nerve. And so it just seemed like a little more scientific with the little electric probes. And once I learned about that, is basically at a meeting I was at, and they talked about it. And then I just took it from there and just did it a little bit. But then we started doing it in earnest. And I liked it so much because I'm always open to helping people with chronic pain. Like, I think we need as many things in our toolbox as we possibly can. And I thought this could be a really good tool also to help people get off opiates. Mm-hmm. And it kind of shows that in the results from our small population patients that we did the paper on.
Well, I don't know that it's that small of a population of patients. I mean, yes, compared to a big 500 or 1,000 patients, but what was it, 33 or 40 some patients in this study?
For 33.
Okay, 33. Yeah. That's still to me, I wouldn't call that a small study. I think that's
it's enough.
Yeah, it's enough to kind of really see what's going on. And then if the academics want to dive into it a little bit more, at least this serves as a good platform for them to construct further studies and that type of thing. But I think you got a real sense of what's going on with 33 people,
Exactly.
Yeah.
And I think we accomplished that.
Yeah. All right. Well, so you see the peripheral nerve stimulation concept. It might help you, or I should say the vagal nerve stimulation concept. It may help you with pain and reduce opioids and those types of things. But what the hell went through your brain about, I'm going to look at cytokines? How did that little bee get in your bonnet?
It just seemed like a smart way to really check objective evidence of this.
Right. That's brilliant.
Huh?
I said, that's brilliant.
Yeah, that was basically it.
Well,
and we did that towards the end of our using of this device, but we just were seeing these really nice reports back from patients, and not only doing subjective reports. We have 4 different things that we check subjectively, but that would be another nice way to really see what was going on. And that's basically it. A smart way to do it.
Yeah, no, very, very smart. And in your study design, I noticed that you would stimulate them for about 2 weeks, take them off for a week, and then stimulate them for another couple of weeks. Why was that? Is that just because of the irritation inside the ear, or what was the impetus for that?
I honestly can't tell you why exactly there's that rest period, but most people tolerated it fine. And just so that your listeners know, they would be stimulated for 2 weeks, with this device on the ear, a little battery on their shoulder, and then it would be turned off for a week, and then they'd reapply another one for 2 weeks, off for a week, and then third time for 2 weeks, and then they're done.
Okay. And you're
So-
only stimulating in one side, right?
Exactly.
Okay.
Yeah.
Has there been any studies where they stimulate both sides?
I'm not sure.
Okay.
Not sure about that.
That was just something that, I had kind of a little bit of wonderment on, if maybe, I guess some of the problem is if 50 milligrams is good, 100 milligrams must be better,
Right.
which we know is not, we
So
know that's not
doing
true.
both sides at one time?
Yeah.
No, we did do that. Yeah.
Okay.
Yeah.
All right. Because I know that there are other types of vagal nerve stimulation that actually stimulate both sides at the same time.
Oh,
but
okay.
but they're not a percutaneous. They don't have needles going through the skin.
Right.
So maybe that they need that extra exposure or whatever
Exactly.
to get to the level of stim that they really need to have.
Yeah, the electrodes really excited me. I thought this sounds smarter.
Yeah. Yeah. Well, I think it augments the delivery,
Exactly.
I mean, the vagus nerve is really a pretty easy nerve to access as well, because it's not, they say it's only about 14 to 16 millimeters below the skin. So it's not like it's this deep structure that's hard to get things to.
Get there.
But yeah. All right. So let's go into the study a little bit. So you looked at them, you took blood before you started. And then when did you sample them again to do another blood analysis?
We did it on day one. We did it before they started, and then at
Okay.
week 4,
Okay.
and then at week 9.
Okay.
At
And
week
you
9
were,
was at the completion.
okay. And you were looking for what? All of the different interleukins, the cytokines?
Exactly, looking at interleukins and cytokines primarily.
All right.
And then they're also surveyed. We had VAS scores that we're looking at, the disability index,
Right.
to see the activities of daily living, if those are improving. Also depression scores, and then activity levels.
Okay. And tell everybody what you found.
Well, I jotted down the numbers. I can't remember all these percentages, so I wrote them down here. But yeah, pain reduction on overall for all these patients averaged about 38.5% reduction of pain.
Okay.
Depression, 43.6%, 43.6 improvement of that. Reduction of disability, 38.6%, and increased activity was 26.1%. And we had 40% reduction of opiate use.
Okay.
And we had 3 subjects that quit opiates after treatment.
And you had, I can't recall, but it was a fairly significant pain reduction on the VAS scale for the majority of folks.
Exactly.
And what about, so was 8 weeks enough to just do the whole deal, or did some of these people have to come back for more stimulation post 8 weeks?
That question kind of remains because we quit doing it.
Okay. Okay.
And so, but in the course of doing this, I don't have numbers on that, Steve, but quite a few of them stayed better longer than I thought. And as I recall, not many of them needed to have second treatments.
That's pretty interesting. So you have somebody in horrible pain,
Right.
and they undoubtedly have central sensitization. This seems like a pretty easy way to attack that
Right.
for that patient. And, maybe
Exactly.
it's doing enough of a reset.
And it was memorable for me too. A lot of them that were very depressed, it really helped with that a lot.
Right. Right.
Yeah.
Well, and it's impossible to have chronic pain that's affecting your life every day, all the activities that you want to do without becoming depressed. And then it's this vicious cycle because pain begets depression, depression begets more pain. So it's
Exactly.
just this loop that keeps going around and around. So by breaking up the depression and the anxiety, it's pretty hard not to believe that you're going to help them from a pain standpoint.
Exactly. Yeah.
Yeah. So I noticed in there too that y'all took some urine samples on them. Was that just for toxicology purposes, or was there something that you were looking in the urine for, like neurotransmitters or something like that?
Or toxicology.
Okay. You just want to make sure if they were on opioids, they stayed on opioids.
Right.
Okay.
Yeah.
Did you find anything interesting in that?
No, I don't recall finding
Okay.
any. Yep.
Okay. And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today. Reminds me of this one lady that way back in the days before the onset of peripheral nerve, and I had been to a pain conference and got into,
Really?
some of the toxicology studies, and it was really interesting because she had a standard bunionectomy and but yet had this incredible post-op pain, and I kept writing opioids for her, and the husband was always there, embellishing how much pain she had and all this. And I said, well, let's get a urine test and do a little tox here to see. And interestingly enough, she had 0 opioids in her urine. I'm quite sure they were all going into the husband or significant other or whatever. But as soon as that cup came back with no opioids
Right.
detected, it was interesting how the patient never came back and never requested any more opioids again. It was very powerful.
Memorable.
Yeah, exactly. But anyhow, so how hard is it for application of intra-auricular stimulators? Is it pretty
hard to do it? Pretty simple.
Yeah, pretty simple.
Just adhering it to a specific area on the ear has to be taped on. Most people, there's a power that you have to adjust to where they kind of can sense something, but hard to describe. But it just might be a little bit discomforting by the ear. But then you lower the power, so the power level was always set, and then it would not be adjusted for that 2-week period. And by the way, it does stimulate it's not a constant stimulation. For every hour, it's off for 20 minutes.
Okay. So it gives everything a little bit chance to
Right.
equilibrate and rest. How do you titrate them as far as the dose of electricity?
Right. Every time we would try to up the power.
Okay.
In each
And
application.
were there any complications in your 33 patients? I saw that one patient patient quit because of sleeping problems or something on it.
No, we might have had a couple that we pulled out because it was uncomfortable to wear, as I recall, but there weren't any adverse events at all.
No subcutaneous infections.
No.
Oh, that's great. So that says a lot. You got a minimally invasive, minimally fuss and muss modality that can significantly help you with this tremendous problem of centralized pain.
Yeah, exactly.
But very cool. And it looked like that you worked in conjunction with Dr. Tennett's clinics on this.
Correct.
Yeah.
Yeah, he yeah, he wanted to co-author this. He saw this, and I really, and you know him, and he's very well respected
Right.
in pain management. And I thought, him saying it's probably the best he'd ever seen. A
That says a
study for
lot.
vagal nerve stimulator meant a lot to me, and he wanted to make
Right.
sure, with his name on there, it got published. And I really think this is a really good thing in medicine with chronic pain, as a good study going forward. So hopefully this can be an
Right.
opportunity in the future in healthcare.
Well, I
So,
think you're saying a lot here because you've got demonstrable changes in inflammatory cytokines, and you
right,
have reduction in anxiety, reduction in depression, reduction in opioid consumption, improvement in activity, and I mean, how much more can you say? You know?
exactly. And there are a lot of people was like neuropathy or nerve pain, but it was all over throughout their body. It could be back. It could be, you know, it wasn't just nerve. It mainly was nerve, but it could be other issues that they were having too, because so many issues that we have are based upon inflammation.
Well,
I think that's why
exactly.
it had a very big scope of help that would offer people.
I can't think of any neurological condition that doesn't have some component of neuroinflammation.
Exactly.
You
Yeah.
know, so
Yeah.
um, oh, that's the problem with medicine and surgery now, is that nobody really looks globally at the host, the patient. You know,
Right.
does this patient have a metabolic thing? Oh yeah, they have this nerve that's pinched, peripherally, but why'd the nerve get pinched? What else is going on with them? What are their other comorbidities, so to
Right.
speak? And this is kind of a way to kind of clean the table
Right.
with all of those other things. And
And and it's good too because it's, we as peripheral nerve specialists and surgeons, and I think because of people like Forrest Tennant, we're understanding centralized pain better
right,
than ever. And I mean, is it possible that this reduces that centralized nervous system sensitization to pain? And I mean, I'm just saying initially, I think we do need more research on it, but seemed favorable. Like, is it possible to reboot that,
right, right.
in the central nervous system so that it is a long-term solution?
Well, the problem is that anybody who gets involved in chronic pain quickly realizes and is very quickly humbled about how complex and how disastrous it is for that individual patient. And so
Right.
anything that we can put in our armamentarium to help fight against this very difficult problem, and especially with this because it's such a low risk, high benefit
Exactly.
modality, I have to admit I'm a little ashamed that I haven't really dived in on this more, because I think a lot of patients could benefit
Could
greatly
benefit
from
from it.
this. Yeah,
Exactly.
yeah.
Yeah,
I
and there are people that are, a lot of people are too unhealthy or morbidly obese and whatever, that
right.
because of their health, they're not good candidates possibly for surgery.
Or just as an adjuvant, like let's say they have CRPS and
Yes.
it all started with a cut nerve when they dropped a glass of water on top of their foot,
Right.
and you have to take care of the nerve because you have to get rid of that chronic pain generator, but it's already centralized. So now,
Yes.
why wouldn't you not want to add that on?
Yeah, there you go. Yes.
It's another just another. You don't want to add on things that are ridiculously dangerous or
Risky.
risky, or
Right.
make them worse, or some kind of drug dependence. Those are things that we're always thinking about. But this seems to be like, well, pretty clean and simple. And if it
Right. Yeah.
doesn't work, you haven't taken the patient out of the day-to-day game of what they're normally doing.
Yeah. Very, very low risk.
Yeah, exactly. So any further ongoing research with this, or you kind of
No, that's
report?
pretty much
That's
it for now.
Okay.
Yeah. Be nice
and then-
later time, but not right now. Yes.
Yeah, maybe in the future. So what I was going to say is, how much did the cytokines change? What
I
was
think
it that
it's
made it?
interleukin 10. I don't have all those numbers, but I think interleukin 10, I have to look at this real quick. I think it went up 100%.
Interleukin 10 is one of the pro-anti-inflammatory cytokines, right?
Exactly. Right.
Okay.
All the other one, the bad
Greatly
ones,
decreased.
the inflammatory ones went down, but it's the one that fights inflammation went up.
Interesting.
Through here, I think it's 100%. So
that's pretty interesting. And
yeah,
sadly,
about 110% by week 9. Yeah.
Of what, interleukin 10?
What's that?
Of interleukin 10?
Interleukin 10.
Yeah.
Yeah,
And then
right here, right there.
Okay, let me see that. I think I have that.
All the other ones are showing, downward.
Oh yeah, here they are, cytokine levels. Yeah.
Yep.
That's pretty cool.
So that's pretty profound.
Yeah, that is extremely profound. Pretty cool. Anything else you want to add about it? I think this is a great study, Jim, because it really hasn't been done in the literature, to my knowledge, where somebody's actually looked at cytokine levels. And I think, quite frankly, I think that we should be looking at these levels in almost every chronic pain patient to at least have a baseline to see how inflamed they are. And
that's a good point.
Yeah,
I think it brings to our colleagues that do peripheral nerve surgery. I think it's just good to understand this and not forget the central nervous system with pain, and not get too tunnel vision with peripheral nervous system. I like what you said earlier about it's an adjunct. You might have to get rid of the pain generator in the lower extremity, but something like this could be nice in the future to use just to augment and calm down the centralized pain.
Well, and I can even see a lot of preoperative indications for it as well. So if you're able to maybe address their inflammatory component before you even take them to surgery, that could be, of benefit.
Better results from that.
Right.
That's a good idea.
Yeah. So it's really good. Anything more you want to say about this? I would encourage everybody to go look at this paper. It was published just 2023, and it's in the International Journal of Pain Management. You and Dr. Forrest Tennant. And for those of you who don't know who Dr. Tennant is, I've actually been fortunate enough to have him on the Pod of Inquiry for 3 episodes. He was actually our inaugural guest, and we talked about his defense work for Elvis Presley's doctor and in the Howard Hughes case, which were fascinating. And then I brought him back again to talk about Doc Holliday, because he wrote a great book. Forrest has written a number of books, and they're always so entertaining. Anyhow, so very cool.
Okay.
No, he's wonderful. Jim, thanks so much for taking the time to come on, and I look forward to seeing you and hearing more about other research that you're doing, because you're doing a great job, and I can't think of anybody else in ANS that's doing more right now than you are from a research standpoint. So I thank you for that.
Okay, really appreciate that. And again, thank you for, I mentioned the previous episode, but you were the one who introduced me to all this, and it's been a toxic relationship with these nerves, Steve. I'm not sure if it's ever going to end.
It's a very seductive mistress, isn't it?
Yeah, it is. Yeah. It's just that way. It's toxic, but it's our passion, and I appreciate all you've done and introducing me to all this. It's been good.
It's my pleasure to work with y'all.
All right.
Well, if anybody wants to get a hold of Dr. Anderson, you can find him up in Fort Collins, Colorado, or his other location just north of Denver, which is it Broomfield?
Broomfield, yes.
Okay.
North Denver.
Okay. Very good. So encourage you to, if you have any interest in this, reach out to him. Definitely look at the paper, because I think this is really the first of its kind where somebody's actually looked at cytokine levels pre and post intervention with vagal nerve stimulation. So thanks, Jim. Appreciate you.
Thank you.
And let's get together soon.
Okay. Thanks a lot, Steve.
This episode is sponsored by Savant Sellers, providers of boutique Tier 1 REDs at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley. and you come across some of the juice from Savant Cellars, you may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at SavantCellars.com. That is CEVANT Cellars.com. Spelunk15.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.